Okay, so thank you everybody for attending today's webinar on Foundations for Change. My name is Sarah Raverstein and we also have Katie Smith presenting today. So just a quick bit about the Improvement Foundation. So we are a national not-for-profit organisation that provides training and consultancy services in the development and delivery of quality improvement techniques and programs. You may have heard of us through the Australian Primary Care Collaborative Program, or the APCC, which we developed and managed for a number of years. We have worked with thousands of health services around Australia to implement quality improvement initiatives that aim to improve health outcomes for patients or clients, to also improve the efficiency and effectiveness of services by streamlining their systems and reducing their costs, and to improve population health more broadly. Now we have 4 learning objectives today, and I'll just let you read through those. So Foundations for Change. Today we are talking about 3 key elements for change. We're talking about the team, the data in your systems, and your systems. But where do we start? So you've got all these ideas about changing the team or your data or your systems, but that's really easy to say, okay, we want to make those changes, but it's a whole lot harder to actually implement them and do it in a systematic way. So before we actually discuss the team and the data and systems, we thought we would talk to you about a quality improvement tool called the Model for Improvement. The Model for Improvement is a simple tool to test and implement change, and it also helps you achieve results by breaking change into small steps. So we've got these great big ideas, but how do we implement them? We're going to break the ideas down into small achievable steps. And it can also be used by anyone in any industry, and it has been used globally around the world for some really good projects. The Model for Improvement has 2 parts. It has a thinking part, which comprises of 3 questions, and also the doing part. So what we're going to do is we're going to actually watch a 3-minute video now which talks to you about the Model for Improvement, just to give you a bit of an overview.
This video will introduce you to the Model for Improvement.
What is the Model for Improvement?
It is a simple tool designed to test and implement change based on the principles of quality improvement.
Why use the Model for Improvement?
It has been designed to help you test changes you would like to make, to improve a process or a system in your workplace, or even your everyday life.
How does it work?
It is a framework for developing, testing, and implementing change. The Model for Improvement consists of 2 equal parts. The thinking part contains 3 fundamental questions that are essential for guiding your improvement work. The doing part is made up of PDSA cycles, plan, do, study, act, that will help you develop and test these individual ideas.
So how do I start?
You start by answering the first fundamental question, which is, what is the goal you are trying to accomplish? Make the goal specific, measurable, achievable, realistic, and with a time frame.
How will I know that a change is an improvement?
Measure it. Otherwise, it is impossible to know whether you are improving or not. Collect the information you need in order to measure the change. Don't forget to keep the collection process simple and easy to do. Then, after you have your goal and measures, think of some ideas that you can test. There are a number of ways you can generate ideas. If you are working in a team, you could brainstorm, ask colleagues during a team meeting, use a suggestion box, or review other people's ideas and adapt them to your own setting.
Okay, I have answered the 3 fundamental questions, which are, what are you trying to accomplish? How will you know that a change is an improvement? And what ideas can you test in order to work towards your goal? What do I do next?
Once you have come up with ideas, you can test one using a PDSA cycle. Approach it like a list of instructions. It helps to be as precise as possible. Plan. Document the idea, when it will happen, where it will happen, and who will do it. Decide on the data you need to see. If the plan is working, and include any predictions as to what may happen. Do. Carry out the plan and document what happened, including anything unexpected. Study. Analyze the data and compare the results with what you predicted would happen. Use the data to reflect on whether you achieved what you wanted to. Act. Which step do you take next? Keep undertaking PDSA cycles until you've refined the change you want to implement.
I'm still a little unsure. Can you give me an example?
Sure. This is Joe. Joe is always late for work. He's letting his team down and now getting into trouble. Joe knows he needs to change and decides to use the model for improvement. To start, Joe answers the first question, what am I trying to accomplish? Joe sets a goal to get to work on time every day for 1 week. He has created a SMART goal.
So how will Joe know if he is meeting his goal?
He will need to measure his progress towards meeting his goal. Joe can do this by assessing if he arrives at work on time 5 days in a row. Joe then thinks about what changes he can make to reach his goal. He comes up with some ideas. Joe can go to bed earlier, stop playing video games before bed, buy a car to drive to work rather than catching a bus, set the alarm half an hour earlier. Joe decides to test if setting his alarm earlier will get him to work on time.
So what you are saying is that Joe is aiming to get to work on time every day for a week, and to do this, he has decided to set his alarm half an hour earlier. This idea is the basis of the plan in the PDSA cycle.
That's right. Now Joe writes his plan. He details what he will do, for how long, and what he thinks will happen. The data he needs to collect is whether he gets to work on time. Joe carries out the plan. Everything goes well, except for one morning his alarm does not go off, because his phone was flat and then he was late for work. Joe then reflects on his week and realises that setting the alarm earlier has generally worked. He got to work on time, except for the day when his phone was not charged.
Joe looked at the problem, came up with a number of simple ideas and tested one of them. It seems to me that by breaking the problem down, it became less overwhelming for him. But what is next?
Joe now needs to plan his next PDSA cycle to make further improvements. He has decided to try charging his phone overnight next to his bed to make sure his alarm goes off.
Why did Joe test just one of his ideas rather than implementing them all?
By testing just one of his ideas, Joe doesn't invest too much time and money in making big changes that may not work. Testing ideas to see if they work is what the model for improvement is all about.
Okay, I understand about Joe, but can I use the model for improvement in my own workplace? I have had lots of ideas that never get off the ground, and some of my team don't seem to like change.
People are often reluctant to accept changes. We often try to solve big problems by making big changes. The model for improvement helps by breaking changes down into smaller steps. Involve your team in coming up with ideas and testing them, because team members are then less likely to resist change. The model for improvement is all about trial and error. Sometimes a PDSA cycle will lead to a dead end. That's fine, because we learn as much from what doesn't work as from the cycles that do.
I see. If Joe had implemented all his ideas, that could have been a waste of time, money, and effort.
Yes, if Joe had decided to buy a car to drive to work, which was one of his ideas, he would have invested a lot of money and he may have still been late for work.
To sum up, the model for improvement is a tool that helps us to try new things with less risk involved. The Improvement Foundation has over 10 years' experience in implementing quality improvement programs across many sectors. Thousands of organisations have participated in these programs, resulting in improvements in wellbeing for many Australians.
If you would like to know more about the model for improvement or are interested in starting your own quality improvement initiative, please visit our website or contact the Improvement Foundation on inquiries@improve.org.au or 1800 173 868.
So, the model for improvement. Joe worked out that by making some small changes, he could get to work on time. So he's not at risk of losing his job anymore. But how does this affect yourselves or your practice? So what we're going to do is we're going to give you an example of how the model for improvement works for a health service. So we have the Heavenly Road Surgery, which is a medium-sized practice, suburban practice, has four full-time GPs, a couple of receptionists, but they've decided that they want to focus on chronic disease prevention. So great, that's great. They want to work with chronic disease prevention, but that's such a large goal. So what they're going to do is they're going to break this goal down into a very small steps. So what they're going to do is they're actually going to improve screening for their CVD patients aged 45 to 49 by 50% by January of 2017. So this goal is very specific, it's very measurable, it's attainable, it's relevant, and it's also time-bound, which keeps us on track. So how will they know that a change is an improvement? Well, they can find out from their systems that they have how many 45 to 49-year-old patients that they already have. And then they can find out how many of those patients have already had an ARA, or an absolute risk assessment, using the cardiovascular risk assessment tool. So they can get that information. And it's really important that they get their baseline first, because if you don't get a baseline, there's no way to measure it later and go, okay, well, you know, it's January 17 and we've got 100 patients now that have ARAs, but we need to know how many you started with, because if you only had 5 to begin with, your improvement has been incredible. So it really does need to be measured. So Heavenly Road Surgery comes up with a whole lot of ideas. They think maybe we could advertise the screening by putting a poster up in the room, mail out appointments to patients, contact them by phone, talk to the reception staff about talking to patients when they attend the practice, or even hold a team meeting to canvass for more ideas. The Heavenly Road Surgery looks at these ideas and they decide that they're going to mail an appointment invite to patients for a health screen. So now, from these ideas, they need to plan, do, study and act. And this is what it looks like for Heavenly Road Surgery. So the plan is that Mary will design a letter and post it to 20 patients aged 45 to 49. Now we know that the health service has a lot more 45 to 49-year-olds, but if they have 300 and they decide to test this and they test with 300 patients, that's a lot of time and energy and resources and expensive postage stamps these days. So what they're doing is they're breaking it down into a really small, and they're just testing their idea. So Mary is going to do this on Tuesday the 14th of November, and she's going to do it in Dr. Smith's office, because Dr. Smith doesn't work on Tuesdays and she knows that that's a spare room where she can have some quiet time, or what we like to describe as protected time. They predict that they will have a 20% response rate, which means they'll get 4 people respond, and they will record how many appointments are made. So the next step is to do, and it's done, and it is completed by the 14th of November. But when they look at their results, they can see that out of the 20 letters, only 2 were returned, and so that equals only 10%. So that's a lot lower than they thought. So maybe these days, sending a letter out isn't the best idea, especially with the way technology is these days. I know personally I get lots of letters that just sit in a pile and get ignored. So this may have happened in their surgery. So they're going to now think of other acts that they can do to improve their plan. So they're going to try a similar approach by contacting the patients by phone. And this could be great because Mary actually has a really great relationship, or her receptionists do, with a lot of their patients. So they think this might be a great way to get people over the line. Otherwise, they look at the idea and think rather than approach the patients, they implement a system to offer health assessments when the patient comes in. So a bit more of an opportunistic way of getting people to come in. So I do have a couple of other examples of Model for Improvements and PDSAs that people who have been part of our programs before have accomplished. So one of the goals that they had was to identify patients at risk of coronary heart disease by 30th of November 2016. So that was their goal. Now this practice didn't put any age gap on it, but putting an age gap might have helped hone it in a little better. So they look at the number of patients identified as being at risk of CHD, and this data was going to be collected by their extraction tool, which is the PenCat tool. So again, they would have needed to have started off with how many patients do we see as identified, so that they know how many they've improved by. So the practice nurse was going to collect information from 15 patients using the Australian CVD at-risk tool. The practice nurse then was given half an hour protected time each day each day for 2 weeks, and she was going to collect the information in the waiting room and by the 30th of November. Now she did this and it was quite easy to collect the CVD at risk or using the CVD risk tool. So the study was that the waiting room was not really ideal, but the patients were very receptive and that they don't really need all that time. So again, they're honing in their idea, and this time they've decided that they're going to use it on Wednesday afternoons when the room is spare, because they didn't need every day for 2 weeks. They were going to continue to opportunistically speak to patients in the waiting area, and they were going to give that protected time to one of their practice nurses each Wednesday, and they were going to make that a roster so they all took turns in doing it. And this again is another model for improvement and plan, do and study and act. So this is actually in your slides, so I might just keep moving on and you're welcome to have a look and read that a bit later on. So the model for improvement, one of the things that is really important with this is that it is recorded, that you're actually recording what you want to achieve, because that's really going to keep you on track. So the Improvement Foundation has QR Connect, which is where you can submit data, and it's also where you can submit your model for improvement. So I'm actually going to just bring up QR Connect to show you. So it can be quite an overwhelming process to start with, but as you get more into it, you're going to find that it's just the most useful tool that you can use for your practice. So if you're connected into QR Connect, which is free for you to join and use, and you can utilise just this page alone if you want to. So what I've done is I've actually popped it in already, but all I want to do is if I wanted to add a new goal, I would literally just click Add New Goal. It's going to let me put in what I want to accomplish and how and our measurement. But I've already done, and then adding our ideas. So I've already done this. So I've got my goal here, which is improving screening for CVD patients aged 45 to 49 by 50%. And we know our measurement is those patients between 45 and 49 who have had an ARA. And these are all our ideas. And so what we need to do is if we decide, okay, we're going to mail an appointment. So this is where I would click to open it. And I would add a cycle because I've already got my goal and my measure, and this is where I would record my plan, do, study, act, and then I would submit it. And this is just a really great way to keep everything on one page, all the information nice, clean and clear for you to have a look at and for you to utilise. Now the other great thing is that if you join QR Connect and you've got some other team members you join also, you can all go onto this page and work on things. It doesn't mean one person's responsible, unless of course you've made one person responsible for it, but it's easy for people to come in and use. So the way to join QR Connect if you're interested is you just go on to www.improve.org.au, so you can Google us quite easy. You just need to head to Services and then QR Connect IF web portal, and then that takes you to a Register Now button, and you just need to register, and you can add as many people as you want, and again that's free. I won't go any more into it. You've got the slides, so you've got pictures to help you navigate yourself to that. Okay, the team. So this, I'm now going to pass you on to Katie Smith, who will be talking to you about the team. Thanks, Katie.
Thanks, Sarah. Hi, everyone, and thanks for joining us today. So this is the first of the 3 key elements for foundational change, and that's working out who is in your team. Sometimes it's easy for us to think that we work in just one team, which is the team that we, excuse me, the team who works in the general practice or health service. But it may be that you have a number of smaller or micro teams within a service in which you work. For example, all the practice nurses would form a micro team. Sometimes it's good to reflect on who actually decides who are members of that team, because that can often give you an advantage in working out what kind of activities around prevention you may wish to pursue. And that could be because it's based on a clinical interest, for example, patients with diabetes or patients with coronary heart disease. And so these are some of the ideas that we've identified that are key features of successful teams. One of which is that everyone who works within the practice or the service has a role. And that role may vary according to whether or not the individual team member is a clinician or whether their role is more to do with administration and management. But everyone needs to feel a part of that team in order for any change to be successful. What's really important is to have a shared vision so that everybody is striving towards the same goal. Some services and practices will have a mission statement and will have a strategic or business plan which formalizes those goals and that vision into a document that people can have access to. And extremely important are some of the softer skills, such as mutual respect and trust. Without trust and without supporting each other as a team, nothing will be changed successfully because people will not be willing to undertake any kind of changes if they don't feel that they have a role to play and that their role isn't important. So how do you support your team? One of the key features is to make sure that a staff member or a number of staff members have been designated to support the team. Now this may be something that's out of your control, but hopefully it is something that your practice principals or your practice manager understand is key to ensuring successful implementation of change ideas. This particular role may actually be part of a position description, or it can be something that people are upskilled to undertake. And that will require them to do something to make sure the team is supported. And there are a number of different activities that we've presented on the screen to you. The key component in quality improvement activities is to measure your progress and to provide feedback to the whole of the team on how you're going. And as Sarah mentioned earlier, we use the term protected time, which allows people to reflect on the changes that have been made and, excuse me, on the changes that have been made, and to ensure that those results are shared across the team. Joanne mentioned communication as one of the most successful elements in her team. And I think that without efficient communication and effective communication, it's very easy for team members to feel excluded and to not want to contribute to any change improvement efforts. As much as it's important to have internal communication with the team, it's also really helpful to highlight it and celebrate it externally. Some of the general practices that we've worked with over the years have really utilized social media or their local media to demonstrate what it is that they've done. This reassures patients that the practice that you work in is always striving for excellence in the care that they provide to your patients. Your local PHN may also wish to be involved in celebrating and sharing your successes. So we encourage you to get in touch with someone from the PHN and see how you can work with them to demonstrate the improvements that you've made in your general practice. So as was mentioned in the video, sometimes team members are reluctant to undertake any change. Building a team can be a slow and methodical process, and it's important to remember that it's difficult to have the whole team on board straight away. If you have a particular goal you would like to achieve, it might be worthwhile to begin by working with a couple of enthusiastic team members to begin with. As you continue on the journey of change, and as the team around you sees your success and your enthusiasm, you'll find that others will want to get involved. You may also find that by using the Model for Improvement tool that Sarah discussed earlier, people will not feel so overwhelmed with what you are trying to accomplish because you can break change down into small steps. As we discussed a little earlier, asking for other people's opinions and giving those ideas honest consideration is another great way of building the team. And we have many examples of people that have found skills and brilliant ideas from team members and that they were not aware of prior to asking them. The Improvement Foundation ran the Australian Primary Care Collaboratives program for 10 years. And the fundamental aspect of those programs were teamwork. And the reason for that is that in order to make any successful change, we need the foundation work of strong teamwork, an enthusiastic and empowered team, to enable any challenges that are being faced to be met by a strong and powerful unit. With regard to the Heavenly Road surgery example, they found that it wasn't until they hit PDSA cycle 4 that a change in team culture, awareness and intelligence began to occur. So without dedicated support, the team will end up in mourning. And I'm going to discuss what I mean by that over the next few slides. The better that you know your team, the easier it is to support them. And also sell yourself. As we mentioned, if you share your successes with your other team members, they're more likely to want to join you on the change journey. So, as we mentioned, without support, people often end up in mourning. And there's some very good research that's established why this is so. Transition is the process that individuals go through when they're faced with a new situation. And that can be the same in their personal lives as well as in their professional lives. The change is the situation that's occurring to them. So change is situational and transition is personal psychological process. Change is what happens to people and transition is how people deal with it. William Bridges has written extensively on this and has quite a well-known and well-discussed model called the model of transition. So when a new situation arises, transition requires that people let go of the old way of doing things. And that can sometimes cause people some anxiety and some grief because they were quite happy with the way things were and they don't really feel that it's important to change. Once the change effort is underway, people then enter the neutral zone, whereby they're not sure if they're keen on the new change and they're beginning to let go of the way things were done before. Once people work through the neutral zone, they then get to the new beginning, which is where they start to embrace the change and think about what can be done next. And this process occurs over a period of time and will vary from individual to individual, depending on their own characteristics as a person, and also depending upon their experience of change and how involved they feel in the process that's going on. And here's another model that I think really exemplifies what we mean by transition. And this is John Fisher's work from 1999. And it provides a really strong analysis of how individuals deal with personal change. And it's useful to not only understand what people are going through, but also for organizations to help their staff deal with change. As you can see at the bottom of the curve, there's threat, guilt, depression, and hostility. And if those aren't dealt with and addressed, people won't be able to move forward, and they will be in mourning, as we mentioned on the slide a little while ago. With any change activity, there will be an element of grieving. If people don't see the need for change and the vision hasn't been shared with them, they will be in denial that there is any reason to try something new. And denial can often lead to anger and resistance because people have not understood what it is that's trying to be achieved, nor their role in it. Once people are informed and are engaged in the process, they will then begin to move away from grieving towards accepting that the change is real and embracing it. And the change equation demonstrates the importance of what to do to avoid people getting stuck in grieving or in mourning for a situation that used to occur. D stands for dissatisfaction, and it may be that the practice principal or someone within the practice has decided that they're dissatisfied with the way things are and they would like to try something new. That's fine for the individual, but unless that vision is explained to the rest of the team members, that dissatisfaction will sit with that one person and will not be translated. So as important as a vision to explain what can be better, practical first steps towards reaching that vision need to be explained to people. And it is the combination of the dissatisfaction, the vision, and the first steps that will overcome resistance. All three are required in order to move to a new way of doing things. I'm now going to hand back to Sarah, who's going to talk us through the second key element of change, which is data.
Thanks, Katie. So why is data so important? Data in the form of a clinical record provides a view of your patient's health status, and it can be used to diagnose a condition and determine appropriate treatment. It can identify health-related risks. It can help maintain a condition and minimise the risk, and it can also ensure that care is provided safely. From a practice or a health service perspective, data can be used to identify improvements in a health service system. It can efficiently manage groups of people with similar health conditions, and it can inform resource planning and reduce waste. Data can also help you prevent disease, morbidity and mortality. If risk factors are accurately recorded, you can analyse your patient population to find people at risk of certain diseases. You can then act early by implementing effective programs such as smoking cessation or prescribing blood pressure medication or statins to help prevent your patients from getting sick and deteriorating, and to prolong a healthy and active lifestyle. Your health service team should always be trying new ways to do things better. But how do you know if the changes you make are achieving the desired results? Sometimes we improve one thing only to find it has made something else worse somewhere else. This is where data quality becomes important, as it will tell you what is working and alert you to unintended damage your improvements might be making. Good data quality is a powerful resource for a health service, but requires a consistent and coordinated approach from all of the health service team. So data collection is the cornerstone of quality improvement. By measuring what happens when changes are applied, we reduce placement of ineffective solutions. We can see whether changes lead to improvements. We ensure that improvements are sustained. It allows comparisons of performance across different sites, and we also recognise successful performance. So what kind of data are we talking about? And we're talking about it at three levels. We're talking about practice data. So this is the data that you have at your health service. We're also talking about local and regional health data. So that information can come from your primary health networks, from SA Health, Health Direct, peer practices. So get an overhaul of or a look at what is happening in your area. Maybe there is something that you need to be looking at more particularly than others. And then, of course, you've got your state and national data, and they're from some of the key foundations like the National Heart Foundation, Drug and Alcohol Solutions, Australia Kidney Foundation, Diabetes Australia, etc. So to get the most out of your clinical software, data needs to be collected accurately, recorded in the right place and maintained over time. If not, patient care can be compromised and efficiently and reduced. So talking to a doctor that works at a very successful practice last week, one of the things he discussed was that everybody was on board with the way that they recorded their data. And in fact, it was so important to their practice that they wrote it in a policy so that everybody was aware of how they recorded the data. And they also made sure that when people first came to the practice and were orientated, that they, one, agreed to be able to continue with the way the practice did it, and also so that they set it up immediately for this is the standard that we expect from our practice. When you have good data quality, you have accurate, accessible and comprehensive information that can be used to improve the care of your patients. Improving data quality is a job for you and everyone at your health service, and maintaining it is an ongoing process that requires monitoring. It is a job worth doing because data quality is critical for improvement, delivering high quality healthcare and effective reporting, whether this is internal, so to management or the board, or external, so reporting, say, to your PHN. To have good data quality, you need to accurately capture and record individual patient information, continually update data to ensure it is accurate, as we know that data rapidly goes out of date, makes data quality a priority for the whole team and part of how work is done on a daily basis, and also review your data regularly and work with others to share ideas on improvement. As you improve your data quality, you will become more efficient and effective in redesigning patient care to address the needs of your patient population within the business constraints you face. So, some benefits of clean data and some information. You can't change everything at once. People who have been doing things one way, it takes a long time for them to change, and it can cause resentment. But you do need someone dynamic to lead and drive change. It doesn't mean you need the whole team to start with, but you do need a couple of change champions. Ultimately, the aim is to improve patient care, and that needs to always be at the forefront of change. Correct coding will impact outcome, and your income, and we are all by nature fairly competitive, so maybe you need to utilise that to your advantage. So using someone to, getting someone to maybe get on board with data collection and cleaning your data is a really good start. And it doesn't need to be everything either. You can just pick one perhaps chronic disease. So maybe look at diabetes and look at your, how many patients have diabetes cycle of care. And you could start just cleaning up your data there. So again, we're not suggesting these massive overriding changes, but just small little steps. You might find that you've already, you're great with diabetes, and maybe CKD is something that the practices need to look at, and so you start looking at databases around that. So you need to decide who's going to manage and collate your data, who inputs it. Of course, the fourth coding rule means that all the GPs and practice nurses need to definitely get on board. And then who manages at-risk or identified populations or registers. We need for you to be reviewing your practice populations. Who are you going to target? So again, which chronic disease perhaps are you going to target to begin with? Formulate your goals and then select your measures to track your progress. And then you need to review those regularly. And once you start reviewing them, you'll be able to ask yourself, how can we improve? So as an example, Wave 8 of one of the programs that people worked with Improvement Foundation, or worked with the Improvement Foundation, was diabetes prevention topic, and it was diabetes risk assessment. And from what you can see, at the beginning of the wave, they really weren't doing it at all. But each month, they started improving and adding to that. And at first, it was a fairly slow change, but as they got the hang of it, it just grew. And by the end of it, it was just part of what they did every day. And then Wave 9, this health service had already worked with us, so you can see that this quickly changed because they'd already installed some of their processes. And again, these are just another couple of examples. Now, absolute risk assessments for the practice nurse wave, that was something new that we'd introduced. So again, it was a bit of a slow uptake, and then it just grew as people found really manageable ways to get absolute risk assessments done.
I guess that's just to sum up what Sarah's saying, is that data can be used in a number of different ways, particularly when you're trying to engage some of your team members in making changes. So the data can be used to demonstrate that there is a need for change. As we talked about in the change equation, if you like, it demonstrates the dissatisfaction because it highlights that there is a problem that needs to be addressed. Over time, as the measures are collected and reviewed, it can be used as a motivator to show people that what you're doing is actually having a positive impact. It can also be used as a driver so that some of those team members who haven't really been engaged in the change may see the results demonstrated in objective data and decide, okay, this really is working and it's worth my time and energy to be involved in this. And finally, at the end of any change effort, it will demonstrate that what you've done has worked. It will allow you then to justify future investment and use of resources to make changes in other areas within the service in which you work. So there's 3 ways that data can be used along the improvement journey. So I'm sure it's something you're all familiar with, the recall and reminder systems, and as we know, it's really the backbone of chronic disease prevention and management, because without it, it's impossible to implement a systematic and proactive approach to identifying at-risk groups and to use the data to make sure that you have recalled the appropriate patients for screening. It's also used for secondary and tertiary prevention. So for your patients who are already diagnosed with a chronic disease, the recall and reminder system helps you to make sure that they're maintaining their health as well as they can be to reduce any further deterioration in their condition. We've had a little discussion about planned versus opportunistic, and we'll look at that on the next slide. And I guess one of the things to consider in the system is who manages the system and who has oversight. Have either of these been designated to an individual? Is it one person's responsibility, or is it shared across the team? And if there's oversight, so if someone is managing the system, does that person need to be clinical, a clinician, or can it be someone who works in management and or administration? So planned versus opportunistic. And there are a number of different ways that you decide you may wish to plan prevention activities. Some of the examples from participants in previous programs include the 2 bullet points on the screen in front of you. We know from some research from the University of New South Wales that whilst blood pressure and smoking status risk factors are recorded well in general practice, waist measurements and BMIs are not routinely recorded well. So if that's something you decided you want to focus on, you could select a week once a year and ensure that all your patients who walk through the door have their waist measured and that waist measurement added and recorded appropriately in the patient record. And opportunistic is exactly as it sounds. So when people present to the practice or health service, the receptionist or the nurse asks them to complete the diabetes risk assessment tool before going in to see the GP or the practice nurse. So those are just some small examples of what can be done. So in order to ensure that the prevention activities you're working on gain the most benefit, it's important to make sure that the processes and systems that you have in place are structured and streamlined to make it as easy as possible for everyone involved, including the patients. If the patients feel like they're being provided with an efficient, effective service that has some outcomes, they will then want to engage much more in the prevention activities you undertake, which will also support them with self-management into the future. That relationships and trust will grow as a result of this, because each individual patient will understand that what the whole of practice is trying to do is to make sure that that patient is as well cared for and well supported with their chronic disease conditions, or to reduce risk factors and make some lifestyle changes as possible. And it's also possible to consider that with utilizing prevention activities can provide reliable financial return via effective use of MBS item numbers, such as the health assessment item numbers, including those for Aboriginal and Torres Strait Islander peoples. So how do we develop the recall and reminder system? How do we do that in a systematic and streamlined way? As Sarah mentioned in some of the examples of the models for improvement provided to you earlier, there are third-party extraction tools such as the Canning tool, PenCat, and Doctor's Control Panel that can help to identify who the eligible patients are for assessments, health assessments, for example. And once you have that patient list, you can then think about which system you would like to utilize in order to recall that particular patient cohort. Sarah gave us the example in the model for improvement about developing letters. And if these have been done in a templated form in your clinical information system, they can be used for any condition or risk factor that you would like to focus on. More and more in healthcare today, we're moving towards a person-centered care model, which reminds everyone that the person is at the center of the care and they determine who their healthcare team is. And in order for them to feel empowered to be in the center of that team, they need to be informed about everything that's going on within the general practice or health service. So with regard to recall and reminder systems, it's letting your patients know that they may be receiving some information from you in a number of formats, such as a letter, phone call, or text, depending on your individual patient populations. And as we talked about before, you only know that you've improved when you evaluate what you've done. So that if one of your patients has been offered a recall and reminder system before and they haven't returned, the first question is why? Are you using the right format to attract your patients? Is it worth considering that this is not the best time for that individual patient to attend an appointment? We all know that the 45 to 49-year-old health check is really difficult to implement because a lot of people in that age group are working full time. So is it that the pro forma templated letter or text that's going out to them doesn't give them the option to attend after hours or on weekends? So managing the recall and reminder system, and again, that comes back to who has oversight and who can manage that system. Is this something that's designated to an individual, or is it something that's part of their position description? So in order to make this system work, there needs to be some protected time. It's also important to make sure the whole team understands the value in utilizing this system, whether it be for prevention or management activities. Whoever's involved in this needs to have training in the appropriate third-party extraction tool or your own software. And finally, none of this is going to happen without the practice owners valuing the system, therefore providing the financial support and HR support to develop and manage the systems. And sometimes that's key to ensuring that a system is put in place, is for people to utilize a cost-benefit analysis of a particular system to demonstrate that this has the potential to work, or once a new system is put in place, that it is actually providing the benefits that will offset the cost of implementing a new system. And that leads us to the end of the content for today's webinar. So in summation, the three key building blocks of Foundations for Change are the right people working together, using the data that you have, both within your practice, your region, and either state or national data, to demonstrate that there's a need to change. The data is also important in terms of measuring your progress and assessing whether you're achieving the goal that the team has set themselves. And the third building block is utilizing the processes and systems that you have within your general practice or health service and tweaking them to make sure that they enable you to work with your team to reach your goal.
Okay, so upcoming online seminars. The next one is Prevention in Practice, Meet Ralph, and that's on November the 22nd, and that's with Dr. Ralph Oldham. Ralph is a Melbourne GP and Associate Professor at the University of Melbourne. He has a passion for managing people with chronic disease as well. He has implemented many programs for diabetes management and prevention, refugee health, children in and out of home care, and is the chair of the expert reference panel for the APCC diabetes topic. Ralph will use a case study to demonstrate the importance of timely prevention activities to reduce the risk of chronic disease prevention. And I've been fortunate enough to listen to Ralph in the past, and I highly recommend that you join him in that session. So Prashiba's presentation on November the 29th, providing systematic and proactive preventative care. Prashiba has more than 8 years experience in primary care and is business manager and director of Mawsons Lakes Health Service, Montague Farm Medical Centre and recently Ingle Farm Family Practice. He previously worked in the corporate sector in telecommunications finance and is a qualified engineer. Prashiba has many innovative ideas regarding engagement of patients, particularly with the use of technology. And I'm again going to say I've heard Prashiba and he is fantastic to listen to. The next 3 speakers, I highly recommend. And then the nurse-led clinics on December the 6th with Ros Ralston. Ros is a primary health care nurse and educator from Nowra, New South Wales. She has a wealth of experience in both acute and primary care sectors and is currently completing a Masters of Nursing. Earlier this year, Ros began a new role as the Skip Into Life project manager at Warragee Medical Centre. Skip Into Life is a nurse-led clinic for people with mental illness. And if you'd like to register for any of those, please go to our website, improve.org.au, and click on the link on the homepage. So I'd like to firstly thank South Australian Health for funding these webinars, and I hope that you've got a lot out of today's session. And thank you so much for joining us. I know it's probably your lunchtime, so we appreciate you taking your time out of your busy day. Thank you so much for attending, and we hope to see you at the next webinar.